for this 45-minute discussion. And I'm very pleased to have, first of all, welcome to everyone. It's great to have you here. I see a lot of familiar names. You are muted when you come in, but you can unmute yourself at any time. So, as I think you probably read in the instructions. So I am thrilled to be able to say that I am joined by Barry Arbuckle, who's the CEO of Memorial Care in LA and Orange counties. And about a year ago or so, Barry was kind enough to be interviewed by actually Dudley Morris, who's also on this call, and me, about his efforts in ambulatory care to develop a real cost competitive solution for the very competitive market in Southern California. And we wrote a paper based on that, which I think we passed out or had available at one of our physical roundtables back when we were physically roundtabling. And it was a pretty good synopsis of what was going on in ambulatory care at that time. Now, obviously, along with everything else, things have changed. COVID changes everything. Ambulatory care is evolving, has evolved rapidly, and continues to evolve, both in terms of the entrepreneurship that's going on, as well as the federal government and the regulatory agencies and what they're doing to it or with it. And so we thought it'd be very useful to have Barry back on with us to talk live with you all about what his concerns are, what his interests are, and where Memorial Care is going. And frankly, Barry is one of many healthcare executives who are leading large enterprises now. And so I think he's familiar and on boards of many associations and so forth. So he can give us a perspective beyond his own system too. So with that, I will turn it over to Barry. Barry, if you don't mind just introducing yourself and telling people for a couple of minutes about your background and why it is that ambulatory care is important in Orange County.
Well, very good, and good morning, or I guess on the East Coast, good afternoon to everyone. And we appreciate your attention because I know there's something else going on in the country right now that might distract you from this Microsoft Teams event, but that we may not know until tonight or tomorrow on some of this. My name, as Dave mentioned, Barry Arbuckle, President and CEO of the Memorial Care Health System in Southern California, LA County, Orange County. I've been with the system actually for over 30 years, which I like to remind my board means that I'm fully depreciated by now. The Memorial Care System, just as a quick background, started probably not unlike a lot of health systems in the country, in that we started as a hospital system for all intents and purposes. And frankly, when I started in the system, the hospitals were in the same system, but you wouldn't know it because they didn't behave like a system. They had different computer systems, they had different billing systems, they had different benefits for the employees, they purchased differently from different vendors. And over the course of time, we began to really weave it into a hospital system that behaved like a system. And then in, say, mid-2000, about 2007 or 8, we decided that we would evolve to something more than just acute care hospitals, kind of beginning to see the writing on the wall that acute revenue would likely diminish over time with shortened length of stays, business moving out of the hospital. And so we went through this effort to expand across the continuum or diversify our revenue stream. And one of the first efforts we undertook was adding a physician division. California has a number of quirks. One of them is an absolute prohibition on any ability for a hospital to employ a doctor, although then and now that was the kind of the prevailing preference of physicians coming out of medical school, maybe not being employed by a hospital, but being in an employment situation as opposed to kind of hitting the ground independently. And so we went through the rather circuitous process in California of creating the medical foundation. uh, decided that we would seed it with a large primary care group rather than try to cobble it together ourselves. And so we acquired what was then Orange County, California's largest primary care group. They were one of the highest performers in patient satisfaction, in quality, had a vision similar to ours. They were actually celebrating their 50th year in existence when we acquired them. And that really became kind of the jumping point for our evolution from a hospital system into an integrated delivery system. And it was also really kind of the launching point for our expansion into the ambulatory sector. An aligned IPA where we share complete risk with the IPA. We do business with other IPAs in the market because in California there's a lot of that. And then we added a health plan, a full service health plan, and then began expanding in the ambulatory side. To your question or request for a comment, Dave, about why ambulatory, it really started as just feeling like the right thing to do. We looked at this very large physician primary care group that we'd acquired. They'd been around, as I mentioned, for 50 years, had very high quality, where all they did was manage care and performed very well. And as a result, when they referred patients to ambulatory imaging or ambulatory surgery or dialysis or transfusion or physical therapy, it was to a community-based ambulatory center, not one under a hospital license. And appreciating the significant price delta, the price to the consumer, whether it be the employer, the payer, the government, or the individual, big price delta between a hospital outpatient department for the same procedure and a community-based, we thought, is it right? I mean, it was tempting, I'll be honest with you, because it would have significantly enhanced the revenue stream of the health system and padded the revenue of the hospitals, and we had complete control over where those patients went. But we decided it wasn't the right thing to do. It wasn't really best for patients. And just what I mean by that is, for years, these folks, and more to come in the future, had been going to a very high quality community-based, let's say, imaging center close to where they live or work, and all of a sudden we're going to redirect them onto a hospital campus. And I love hospital campuses before I started my career, but we're not uncomplicated. Our biggest hospital up in Long Beach sits on 65 acres, and it's just shy of 2 million square feet. It has navigation challenges. And for the benefit of going to a hospital for an ambulatory procedure, you get to pay a price delta of 200 or 300% more for the same procedure done by the same physician on the same patient. So that really started our ambulatory strategy.
So stepping back, Barry, this is obviously an issue that's caught the attention of CMS with their site neutrality regulations. It's certainly, was this group that you bought capitated, by the way?
Yes, they have a significant amount of capitated business, so it made sense financially for us.
Right. So particularly in capitated environments like Southern California, I think it's kind of a natural thing to think about, but passing up the margins on hospital-based, provider-based services is pretty significant. Talk a little bit about how that has evolved in your mind. I know we talked about that here, and just so that everybody is up to date on where the system is now.
Okay. Well, just as a backdrop, when we began heading down this path of creating an ambulatory network across multiple service lines, we started with imaging and then ambulatory surgery, and then community-based dialysis, home-based dialysis, physical therapy, occupational medicine, urgent care. We went about it kind of with the same philosophy, and that is, could we do this ourselves? Could we cobble this together? We've done surgery for over 100 years. Surely we can run ambulatory surgery centers, but we decided how much better to partner with someone who does it for a living. That's all they do. Become a joint venture partner. They probably are better at analyzing market opportunities, pursuing market opportunities, maybe even running it better than we can, which I would say is probably the case. And we followed that philosophy with every one of these joint venture entities that we created in the ambulatory sector. But to your question, the revenue that the hospital system, the health system, has given up by following this strategy, and I'm very open about it with my board and management team, is not insignificant. As we could direct this business anywhere we wanted, and to the degree the hospitals had capacity, with a delta of 200 to 300% for the same procedure, that's a lot of revenue, and the patients are oblivious to it. The health plans haven't until recently paid much attention to it. We'll talk about the federal government in a moment and their approach. Employers, to the degree you have direct contracts with employers, are a little more focused on it, but they really don't know there's a difference because, as you know, hospital-based outpatient apartments don't necessarily have to be on the hospital campus. And so to the consumer, they are generally oblivious until the price point comes into reality. But I don't want to suggest this was an easy path for us. We were committed to it. We were committed to value, and it fits in the value equation. And as we added multiple ACO contracts and direct-to-employer contracts and more risk business, it makes economic sense. But for my hospitals to give up that kind of revenue, we've had a number of discussions over the years that did we jump into this too soon? Have we gone too fast? And I'll be honest, I thought the market would move faster. I thought the feds would move faster, which maybe it's a tough thing to say because they don't tend to move with enormous speed. And frankly, I thought health plans would move faster as they are representing employers. And I would surmise why they haven't, maybe a few reasons. One is, while these dollars are not insignificant, in the scheme of a large health plan, a large statewide or national health plan, the dollars maybe don't really show up on their radar screen. I'll give you an example. We were in a rather intense negotiation with our biggest health plan partner, someone we do about $250 million of business with a year in our health system. And we were arguing over a 1% delta in the contract rates that would be the going forward rates between, I don't know, it was 3 to 4% or something like that. 1%, so that's what, about $25 million, $22 to $25 million. I could demonstrate to them that by our ambulatory approach, that is moving business that made clinical sense to not be done in a hospital setting, in a hospital outpatient department, into one of these community-based ambulatory settings, and I just looked at surgery and imaging just in my analysis, and we did it entirely voluntarily. There was no policy in place by the health plan. They have it now, they didn't then. I could document that we saved them $22 million, and they didn't even notice. When I told them it was the first time they'd heard it. Again, multi-billion-dollar health plan. It didn't show up on their radar screen. However, I believe it's now getting a lot more attention. Certainly CMS, the way CMS goes, the health plans tend to follow, and health plans are beginning to put in policies that really follow our philosophy, and that is there a clinical reason the patient needs to be in a hospital outpatient setting? And why might that be? Well, hospital outpatient settings are proximal to hospitals. They tend to have greater resources available to them. And so for your patients that have multiple comorbidities or are of advanced age, if that's a concern, there's a whole host of things that might suggest, yeah, the patient should have that outpatient procedure done there as opposed to a community-based ambulatory setting. In fact, when we started down this path, and then I'll shut up and let you get back to questions, I wondered, not being a clinician, what percent of cases done in surgery and imaging in our HOPDs, our hospital outpatient departments, so under the hospital license at that higher price point to the consumer, to the employer, individual or health plan, what percentage of them had a clinical reason to be there of all of them that we did? And we had 2 data sets run over a period of time, and the results were shocking, to me at least. In one of them, 78% of the cases done in the HOPD had no clinical reason to be there. It wasn't wrong that they were there, it wasn't against anybody's policy, and that was really the habit of the health system like it is nationwide. 78% in one data set, 80% in another. The balance, 20 or 22%, had some clinical reason to be there. Now, we don't take into consideration, which maybe we should, some might argue, physician convenience. A lot of those cases were to the convenience of the physician, who would have inpatient surgical case followed by a couple of outpatient surgical cases. And it was for their convenience, which is not unimportant. But our view was, we can't burden the consumer or the health system, broadly defined, with our preferences and our convenience. We need to do it where it makes the most sense to the health system.
It's fascinating. We're getting some questions, which I'll go to in a minute, but it is fascinating to me how the health plans would not be more attentive to this. Because first of all, they're talking about it a lot more now. They're talking about moving patients out of and putting patients, as are self-insured employers.
Yeah.
And I know some of the contractors, the ASC contractors and so forth, have approached, are going to self-insured employers in particular, and trying to get them to move their volume. And actually, the percentage that one of those, USPI, was on a previous roundtable here talking about this, and they said that they had a number pretty similar to yours, that they thought that 70% of the surgeries that were done in hospital outpatient settings could be done in their ambulatory surgery centers. And and by the way, ambulatory surgery as a percentage of total healthcare dollars is very substantial, on the order of 25%. So it is a big business, and it is one would think the health plans would be more attentive. Do we have any health plan people on the call here who can explain that?
While they process that question, I've actually talked to a lot of the health plans, because frankly, it fits our strategies that they would move faster, and we expected them to move faster. They tend to start, as I would characterize it, by kind of putting a toe in the water. Almost the classic place they'll start is by putting in a policy that says for outpatient MRIs or CTs, in order for them to agree to authorize them and pay for them in a hospital outpatient imaging center, they have to meet certain clinical criteria. So that's where they'll start. They will invariably get pushback from the hospital industry, because a lot of hospitals have not developed an ambulatory network that's off license. And in part for us, I didn't mention this, one of the benefits of us getting into this early, even though it probably economically was not to our, if not clearly was not to our financial benefit, is that in every one of these partnerships we've established, and every one of these service lines with someone who, as I characterized, does it for a living, we have an exclusive. We are the only ones they can work with in the entirety of South LA County, Orange County. And so I have my competitors increasingly sending us business into one of our joint ventured ambulatory centers, and they probably don't even know it. But when I talk to the health plans, again, it was kind of off their radar screen, even though it's an increasing dollar amount, but it's getting on the radar screen faster. United in California just came out with a multi-page list of procedures across 12 or 13 body systems, as they've characterized it, that they are going to follow the policy of, if it doesn't fit certain medical criteria, they will not pay for it or authorize it within an HOPD. And we're seeing more follow suit, but it's only been in the last couple of years. But the response many times is they get pushback from the employers. One, the employers don't fully understand the price delta and the savings that they might be able to appreciate, but the concerns are for their employees. Because if you begin limiting where people can go for a procedure, from the employee perspective, that's limiting their choice. Sure. And employers pre-COVID, when unemployment was at historic lows, employers were very reluctant to allow some of these changes to take place. The pandemic has put a whole different spin on that, because they know, they've been economically impacted, and I think there's now going to be a kind of an inflection point in the number of employers, and therefore then health plans, that begin moving down this path at a more rapid pace.
Shahid, do you want to say anything or make any comment here? I noticed you had an explanation.
Sure. Yeah, hi, this is Shahid. I spent a few years as the entrepreneur in residence over at AHIP, which is the large association of health plans. And basically, what we saw is that the health plans, of course, as a financial instrument, they don't like to move on the clinical side any faster than their employers are shoving them. Like, not
Yeah.
employers are assisting or suggesting. Employers, the biggest problem in U.S. healthcare is not the plans and it's not the providers. It's the fact that the employers do not take responsibility. They make it sound like when we use terms like health insurance and when we use terms like payers, we make it sound like a third-party administrator, like a health plan, like United Healthcare, is not a payer, right? They are the administrator of the money coming from employers. And the employers, I think the point we just made, they're not pushing in this direction. And therefore, why would the plans, whose employers are their primary customers, of course, why would they push it at all? And of course, if the competitors are not and the employers are not, the employers are literally, throwing money out the window every year because plans are administering at what they feel to be their discretion rather than what the employers need by actually analyzing and seeing what they're doing. So until the employers move, and nothing's going to change here.
I think it's
It's a good point, and it's interesting that even health system employers often behave that way.
Mm-hmm.
And they aren't as aggressive. Of course, they have perhaps a conflict of interest, but they are. At least our experience is that a lot of the benefits managers in health systems aren't any more aggressive than the other large employers in their communities. Why don't we move to another major payer, which is CMS, and talk a little bit about what they're doing in this arena with site neutrality and some of the other rules that they've come up with. Barry, do you want to speak to that a little bit?
Yeah, the site neutral payments initially between the HOPD and the ambulatory setting, office-based setting, however they characterize it, when the current administration started going down that path, not surprisingly, it was met with significant resistance from the hospital associations and industry, both statewide and national. My advice, and I became a broken record and got tired of talking at various association board meetings, was my belief is hospitals, you're fighting a losing battle with your just say no philosophy of site neutrality. Now, by saying that, some people think I support site neutrality, and I actually don't. I think it's a blunt instrument and not the wisest move. I think there is a difference in the patients that should be at an HOPD, and therefore then the hospital should be reimbursed more. It shouldn't be the same. We know that to be true. Also, if you look at the payer mix, a lot of these ambulatory centers, particularly the ones that are privately held or otherwise, don't take Medicaid. Some of them don't take traditional Medicare, and they let the hospitals take that. And we all know those tend to reimburse at a lower level. So I think there needs to be some appreciation. So my advice to the hospital associations was, don't just say no, because at some point you're going to lose that game. And I forget where the lawsuits are going back and forth, how many times it's been reversed. But I believe right now CMS has the upper hand on ungrandfathering the grandfathered HOPDs for site neutrality. My argument was use clinical criteria. Surely there are clinical criteria we can say where the patient, the entity deserves to be reimbursed at a higher rate than in a community-based setting. Much like the health plans are doing. In fact, all the health plans are tending to follow clinical criteria. So to me, that would be the better approach. But I can say, having had discussions with Secretary Azar as recently as 2 weeks ago, they are heading down this path with vigor, including, as many of you know, the recent move to do away with the IPO list, the inpatient only list, starting. In fact, I think it's active now or soon, maybe December 1, with 266 musculoskeletal procedures that will be taken off the IPO list. Now, it doesn't mean they're necessarily going to a community-based ambulatory center, imaging or surgery or otherwise. It just means they can be done somewhere other than a hospital. And on that one, interestingly, the feds are using clinical criteria. They're not defining it, which is a little concerning. My fear is we're going to have a series of audits from the feds to see if people have abused that flexibility now to be in an inpatient setting, at an HOPD, or at a community-based ambulatory center. But Azar is very clear that it is his intention to have the IPO list completely gone in 3 years. And I suspect they'll accomplish it. And if there's a change of administration, I don't see anything slowing that down. So I think we're moving down this path.
Interesting. Let's step back and ask a little bit about sort of the changing ambulatory environment. Since you're working closely with a lot of different companies, and since you've been doing that through this pandemic, what changes are you seeing in the ambulatory environment through their eyes or through your own eyes?
Well, certainly during the pandemic, everything slowed down or shut down. California, I think, was one of the first states to, where the governor sent out a directive, no elective procedures, which impacted not only the hospitals significantly, but also these ambulatory sites. In fact, as we track them, in some months we would have 8,000 or 9,000 surgical procedures, and it went down to maybe 1,200 during, say, the month of April. So it was a significant reduction in volume. I don't say I subscribe to this view, but as we talk to consumers and folks that represent consumers, there's kind of a residual fear of hospitals. And if they can, in the past, if they had a procedure and the doctor said, go to the hospital to have your outpatient CT or medical procedure, they would do it. Now they're beginning to push back a little and say, do I have to go there? And again, I'm not subscribing to the view, but the view is hospitals are where the big stuff happens, the viruses, even though hospitals are doing a remarkable job at sanitization and cleaning, there's just this perspective. It's also a place where you can queue up in lobbies and waiting rooms. That's also of great concern. So we're actually seeing kind of a post-pandemic flood or movement to people requesting these community-based ambulatory centers because they have a perception that they're smaller, they're more nimble, they may be easier to sanitize, which again, I don't necessarily subscribe to, and they have kind of less sick people. And so we're seeing a ramping up that I don't believe will diminish even after we're kind of beyond COVID-19.
So that may be, sort of the silver lining for you. And if you were ahead of the game, at least you are ahead of the game, and you're not going to suffer because of that transition, whereas a more traditional hospital system would probably lose more volume to those ambulatory centers.
Another change we're seeing in these ambulatory centers, probably most notable in the surgery centers, is bringing on some of the more expensive technology. In the past, particularly, don't take this the wrong way, but if it was a physician-owned ASC, you probably wouldn't see them invest in a robot for robotic surgery. A lot of money, the reimbursement delta probably doesn't justify it, doesn't make sense. Same with a Mako robot. With these increasing volumes, and frankly, with a market where they can buy a used Mako or a used surgical robot, I'm seeing a lot more of that. Now, it's not good for the hospitals because the hospitals invested big dollars in that stuff and need time for it to recoup that investment. But we're seeing these centers now bringing on that kind of equipment to bring more business into their settings.
Sounds like the equipment leasing business would be a good business to be in for. I would assume more of that's happening in Southern California than most other places, just because there is the private firm, the big companies that are doing ambulatory surgery and so forth. There are a lot of them in Southern California. We had a question from Ori Jacobs. Do you want to ask your question, Ori?
Sure. Barry, do you have or are you considering a hospital at home program, kind of taking this another step?
And that is a great question. And I'm wondering, since I can see you now, I'm wondering if you can see under my desk uh, somehow, because yes, we are. To me, it's the natural extension. Both remote patient monitoring, kind of on steroids, and hospital at home. We're actually working with two different companies going through an evaluation to see, does it make sense? Where does it make sense? And of course, the more risk we take on as a health system, it can make a lot of sense. And to me, that's just a natural, I think it's going to, that movement, both the ability to do remote patient monitoring, self-monitoring, hospital at home, coupled with the forces coming from CMS and the health plans, I believe is going to push even more business out of the acute care hospitals. And again, I don't say that with any satisfaction because we own hospitals. We've owned hospitals for 120 years. They're a major revenue stream in the health system. And I think some of this evolution, and we haven't touched upon it yet, is going to require different contracting strategies with the health plans that the health plans need to be receptive to, because you can't have the hospitals fail in the United States. But to your question, the hospital at home, I think, is a ripe opportunity, particularly when one takes on the risk for a population.
Barry, are you concerned about getting introducing this for your physicians, having them like it, and then using it for patients who are fee for service?
So what concern in what way?
Well, ultimately, these programs, as I read them, reduce admissions, reduce emergency room visits, and if they're used in a fee-for-service population, it's less revenue for the system.
Yeah, fair enough. I mean, that's the kind of the constant struggle we have all the time. I mean, we're moving as aggressively as the market will allow us toward value-based contracts, which have that same effect. I've been saying for a decade that I wish we could do away with traditional Medicare and move to 100% Medicare Advantage. To me, it's just fundamentally better care. It's a better system. It's better financially. Of course, the physicians in that also benefit to the degree they hold risk. So to the degree we're partnered with these physicians, either with our medical group or our aligned IPA, and even the IPAs that are outside that we contract with, they are financially incented to move in that direction as well. Are there still physicians who are a lion's share or a significant amount of their revenue is fee for service? Yes, but particularly in Southern California, that train is leaving the station, and they need to move. Again, you raise a good point. Do I want to be the person that they perceive as pushing them in that direction, a direction they may not want to go? You know, that's a delicate move, but our view is you just got to move, kind of skate to where the puck is heading.
Right. Thank you.
So what kinds of Barry, what kinds of strategies would you, so now sort of take off your Southern California hat and put on sort of a national hat, and realizing that there's a lot of systems that are way behind what you're doing, or more traditional than what you're doing. How do you see this? What strategies should they take to unravel this historical commitment to hospital-based services?
Well, I mean, that's really one of the challenges that health systems face, and we faced it as well. That is, do you invest in this ambulatory network we've developed? So we're taking, capital we could have otherwise spent at the hospitals. We're investing in the ambulatory network only to get less revenue. I mean, it sounds like I flunked my business classes. I mean, it does not make sense unless, and I think I got a certain benefit being in a nonprofit system where we can take I don't worry about, quarterly reports to shareholders who can be quite fickle. And so my board knew this is a long-term game. We believe this is where the country's going. This is where the country should go. Or maybe the better example is the rating agencies, Standard & Poor's, Fitch, and Moody's. We spent a lot of time in the early years explaining to them, here's what we're doing. Here's why we're doing it. Here's what's going to happen. It's going to impact our revenue. And yes, we probably won't have the net income that you expect of a AA rated health system, but here's why we're doing it. And maybe I shouldn't have been surprised, but to some degree, much to my surprise, they've supported us every single year. And they'll acknowledge, you're AA rated, you've got a great balance sheet, we like your strategy, we appreciate you've kept us up to speed. Your net income is not where we think it should be for a AA rated system, but we're going to stick with you. And so, I mean, I have kind of a renewed sense of admiration for the rating agencies to kind of take that big picture view as well. But to your question for kind of outside California, which is in some respects a unique market, not entirely, but it's different than a lot of parts of the country. If the hospital systems can, get their head around and their board's head around making those kinds of investments in their market early, and if they're, we're not as large as some of the monsters in California in terms of health systems. We're just really a regional health system, but we were able to carve out that exclusivity with the big player in the market, whether it be in ambulatory surgery or imaging or dialysis, et cetera. And that's given us a certain advantage, because now I'm in discussions with health systems we actually compete with, asking if they can join into our ambulatory network and how much business they can bring to us. The argument that, you'll have a smaller piece of the pie, but the pie is going to be so much bigger, which there may be some argument, but it puts us in a very good position from that perspective. And it's allowed us to perform exceptionally well in all of our risk-based products. Particularly, and I'll just make this point, our direct-to-employer products. We had what was California's first direct-to-employer contract in the state with Boeing. So we have responsibility for the Boeing employees and dependents who sign up. They have two options, a broad PPO and then this narrower network with the Memorial Care Alliance, as we called it, because we brought in a few partners to help round out the geography to best serve Boeing. And I agree with the comment made earlier about AHIP and the health plans, and they'll only move as fast as the employers push them, and the employers aren't pushing. These self-insured employers who are of size, the Boeings, the Qualcomms, the Intels, the Googles, they are wildly sophisticated. They know the numbers, they know the game. And frankly, in that product, we're at full risk for the total cost of care, total cost, including pharmacy, which is a whole nother story in and of itself. In the first year, we reduced Boeing's total cost of care by 4%, whereas their PPO went up 8%. As an aside, we reduced their pharmacy expenditure in our population compared to the population that wasn't with us by 22%. And it made me pause and say, what the hell is their PBM doing?
Yeah.
Another issue entirely. But my point in all this is this ambulatory network has allowed us to play in that game very successfully, whether it be the ACOs with health plans, the direct to employers, the bundled payment under CMS, or even some of the ACOs that CMS has offered. It allowed us to perform very well because, as you know, when you enter into those ACO contracts, usually a baseline is set. That baseline is the year before you enter into that contract. Well, in that baseline, it included, X number of members. Only a subset of them already went to our hospitals and ambulatory network. Several of them went into my competitors, who more often than not are feeding things into the HOPDs. And so really I had to do nothing in terms of managing care other than what we'd always done, move the patients that can into the community-based ambulatory settings away from the HOPDs, and I could save money immediately and perform well. And then of course, all the other management we have to manage the ACOs effectively. But it puts you in a good position. Again, if you can convince your governance and your executive team, investing this money now, yes, it will reduce our revenue on the short term, but it's a long-term play. At least that's our view.
Mm-hmm. But it sounds like it has a lot of strategic value, particularly as you move to risk. But Marcy asked a question earlier about sort of primary care. Marcy Sindel asked a question about primary care and the various disruptive primary care providers that are, I don't know to what extent they're disrupting Southern California markets. It is already so disrupted. But are you seeing much of that? The One Medicals and the Oak Street and all these other things? Are you seeing much of that in Southern California? And if so, how does that fit into your ambulatory strategy?
Well, it's a very good question. Probably the biggest disruptor in this market, as I would characterize it, is Optum. I mean, it's a beast. They
Yeah.
have more physicians either employed or IPA physicians than anybody in this market by a long shot, other than perhaps Kaiser, which, fundamentally different model. We're fortunate that we have had for 25, 30 years, maybe longer, a partnership with subsets with groups that became part of Optum. And so we tend to enter into shared risk contracts together a lot. Now, that said, it's one of those relationships that is always kind of a fine line, because their preference would be to take global risk, which they can. And then that opens up the possibility, I'm not saying they necessarily do, but it opens the possibility that they can treat the hospitals like vendors, just wherever they get the lowest price because they've got global risk. Now, at least in Southern California and a lot of California, health plans have given some of these groups global risk, a global rate. So they have the professional side and the hospital side.
Mm-hmm.
I imagine from the health plan perspective over the years, that's been, one, is easy because you're negotiating with one party. You might view, and you're probably right, that physician group that you're giving global to probably has more leverage over the local hospitals to get a better price than the big statewide or national health plan does. And that's all well and good. And again, that probably was a good strategy. However, you've got to be cautious because Optum is owned by a very large health plan. And that the revenue that they're producing is going to a very large health plan. That health plan competes with other health plans. So they're almost feeding their competitor in that by giving these kind of global rates. But again, that may be more of a California phenomenon than in many parts of the country.
This, Marcy, maybe if I can just add to that. So, here in Boston at Atrius Health, we took global risk for ages. And really the reason the health plans did it was because they felt that they could get, the primary care providers could certainly send patients to your ambulatory surgery centers over going to the hospital. They could send them to the less expensive hospitals, but also they would work really hard to keep people out of the hospital. So I suspect we're going to see more of that. How do you respond to it, and how are you, how do you think about it from whether it's a partnership standpoint or, or other ways? And I guess the follow-on is, what do you think is going to happen to hospitals down the road? Do you think we're going to lose a lot of the hospitals in this country as a result of, all of these movements that we're talking about out of the hospital?
Yeah, that's a very good question. I think you're right. I think the perception from the health plans was, fully capitate with global risk the primary care group, and they will manage care as best they can. Not good news for the hospitals. And because we've been so focused for the last 10, 12 years on pursuing value and, kind of the accountable care before it was, a name that was terribly in vogue, we've kind of got our mindset away from the heads and beds, which, to be honest with you, is where my career started. And it probably, in the 50, 60, 70 years before me, that's what made sense for the hospital. And hospitals, generally speaking, aren't doing themselves any favors in many ways by not having a off-license ambulatory division, because the numbers, and there's just endless reports coming out from economists and others that are showing a significant price delta for the market between health systems and how they approach this care. To your question about hospitals of the future, that's really part of the reason I made the comment earlier that hospitals today need to be thinking differently about the way they contract for business. I mean, they should already be looking at the IPO list and saying, okay, X number of amount of our business is likely from CMS is going to not be done in the hospital anymore because it can be done somewhere else because it's off the IPO list. What does that mean from a contracting perspective? Because the health plans will tend to follow suit in that regard. They're pushing the business out. So, and the health plans need to be partners at the same time and not, think entirely about quarterly returns and the like, because we need these hospitals to be around. I mean, hospitals, as part of the healthcare food chain, tend to have the lowest margins chronically. Certainly with the pandemic, we have way more than 50% that are operating in the red and show little sign of recovering in the next 3 or 4 or 5 years. Will we see more hospital closures? Without a doubt. And I say that even knowing full well, particularly for nonprofit hospitals, they tend to live 15 years longer than they should. It's just the way it is. But I think we're going to see fewer. I think we're going to see care more regionalized as we continue to see this business being pushed out. So we need a different contracting strategy to keep hospitals available, I think, for the consumer.
Well, that sounds like a great next topic. So we will put that on our webinar list for the future, and it is something that we're, as a consulting firm, we're doing a lot of work in this area now, in helping health systems make that transition. So we've reached our time, and I want to thank you, Barry, very much for participating here. It's always refreshing to hear your perspective on these things. You have such a long history of evolution in this business that we really appreciate your being here. As I think those of you who saw the chat from Maggie Weschler, there is a survey that you can fill out. So if you go to that survey form, we'd appreciate it if you could fill it out and give us some feedback. And meanwhile, thank you all for joining us this noonish, or whatever time it is in your time zone. And we'll look forward to see you in our next webinar. So thank you again.
Nice to see you again, Barry.
Good to see you. Thank you much.
Great.
Thank you.
Bye-bye.